everyone. Welcome to this segment of Ask a Biller. This one is called the first session, Juggling Clinical and Admin Tasks. So we'll move along here. So again, this is just the agenda.
Sorry.
So this is just the agenda that we kind of go over every time. We're just going to introduce ourselves, or I'm going to introduce both of us, and then we're going to skip right to the pre-submitted questions after that and get you guys all the information that you're looking to get. So I'm Avery. I've been working in the healthcare industry actually here at SimplePractice for 3 years now. And after working with healthcare providers and, kind of getting in deep with their practices and everything, I've just come to understand how necessary it is to understand insurance. So that perspective and working with those clinicians and everything has, led me here, and I'm happy to be in this position, helping to disseminate some of the information that is out there and that people need to know. And then the woman who needs no introduction, but I'll do one nonetheless, Barbara Griswold. She's a practice consultant and the author of Navigating the Insurance Maze, A Therapist's Complete Guide to Working with Insurance and Whether You Should. It's in its 8th edition now. Last year, Barbara celebrated 30 years in private practice. She offers non-judgmental insurance consultations to therapists nationwide. And if you have any questions or anything else, she invites you to email her at theinsurancemaze.com, her website down there. So go ahead and do that, and she'll be happy to help you out there. So if this is your first experience with the Ask a Biller series, you can always go to this link right here, simplepractice.com/Ask a Biller series, and you can check out all of the other videos that are up. You'll just have to enter in your email to unlock them all, and you can go ahead and view them from there. The one other thing I want to note is that these videos aren't about how to use SimplePractice or anything like that, okay? These are all kind of separate, but definitely check those out. A lot of good information, and it will definitely be of help. And now we'll move on to the questions. So the question, here we go. So the first one here, how do you screen people quickly before the first session? From Clarence C.
Well, this is Barbara. Hi, everybody. And yes, we're going to go through the pre-submitted questions. And here's the first one here. I've created some slides because there's so much information I want to give you. I have an article that I put together, which is called The Art of the First Client Contact, 10 Tasks. And this is one of the freebies I'm giving away today. I've put them all on one page, which is theinsurancemaze.com/intakes. And as we talk today, I'm going to be telling you that's at that page. I put everything so you don't have to go looking all over the place for stuff. I'm going to put all the links we talk about today at this page. So write it down now, or maybe that you guys can put it in the chat. theinsurancemaze.com/intakes. So the art of the first client contact will talk to you about kind of that whole first conversation that you have with people on the phone, and all the things you need to do on the phone, which we won't be talking about today. We're really talking about the first session today, but I wanted to give you that. Also, I wanted to kind of note here, there is a lot of content on the slides today. So I put together a slide handout. We don't always do that with these webinars, but I've put that at the same location. There's a slide handout, so you don't have to take a ton of notes today. And you can just go ahead and get that. Okay, so in the first email, I don't usually do a free intake, which a lot of people, well, actually, that's a little more for the second question, screening people. I do a very brief screening. So in the first email, really, which is the way, right, these days I'm having first contact with people, I ask 3 questions. I say, before we schedule a session, can you tell me what issues you're bringing that are bringing you to therapy? What days and times are you available for sessions? And what insurance plan are you using, if any? This is for our insurance providers particularly. And if none, or if I'm not a plan provider, my fee is blah, blah, blah. So these are kind of my quick and dirty screening, because first I want to find out, before I go to the trouble of screening them, if they're saying I have a very severe eating disorder and or I have a very severe chemical dependency problem, or whatever the issue is, and it's something that I don't even work with that, I have no training to work with, I want to quickly be able to say to them, that's not something that I can work with you with. So, try to save yourself from getting these people into the first session. It doesn't do them a service, and it doesn't do you a service to have a session with someone who is clearly inappropriate, and you could have screened that from the beginning. Obviously, availability can be an issue. If they need somebody on Saturday, they need somebody in the evenings, and you don't do that. So see if you can do a little bit of this before you get them into the session. And then the insurance plan issue, sometimes that can help you figure out whether they're needing to use insurance and you're not on their insurance. So those are kind of the main issues. Obviously, there's a lot of other things you could do on that call. And again, the article will say more about that call. Then also tell them, okay, we're going to meet and we're going to see if it feels like a good fit. So I right away on the phone call or the email, let them know that our first meeting is going to be, we both are going to get to be seeing whether it's a good fit. There's no commitment yet. So you are going to be continuing to screen. You're kind of telling them in a nice way that we're both continuing to screen each other to see if it's a good fit. So be sure you say that up front. I think it makes it easier if it isn't a good fit because you've already kind of given them notice.
All right, the next question here. What are the forms you give out at the initial session? From Stella L.
Okay, so the forms you give out are going to be different depending on your practice, obviously. But here are the ones that I give out before the first session. I have a registration form, which basically says what their demographics are, their contact information, it even has insurance information, has some basic, a treatment agreement, which is kind of the plain vanilla treatment agreement. You might call it an informed consent. Informed consent really talks about the pros and cons of therapy or benefits and costs, where treatment agreement is just more, here are my policies. So I use a treatment agreement actually. And that is one you give to all your clients, telehealth or regular. And then I have a separate telehealth consent that is really necessary and required sometimes in many states, that talks about, again, telehealth specifically issues and getting them to know like what are the boundaries there, how to set up a confidential space, that maybe you can't practice across state lines, all the things about telehealth that are unique to that. Very important to have this with all your clients. Credit card authorization, particularly if you're doing telehealth. A lot of us are running people's credit cards and we don't have an authorization on file. I would encourage you to have an authorization that says when you can bill credit cards, in what situations, and are you going to bill them after the session, before, at the end of the month, etc. And most of us need to have a HIPAA notice of privacy policies that we give to clients and have them sign that they received it. Try to get this down to as few as possible is what I would say. Don't overwhelm clients. We already are giving them so much. I try to get them down to as few pages as possible and as few pieces of paper to give them. Where do you get those forms? I have a practice forms packet available at my website that includes all of these and many more. There's 18 forms in there that people could need. SimplePractice has a sample form template library that you can use. I've put the links to both of those again at this landing page I've created for this webinar, which is theinsurancemaze.com/intake. So if you want to find out, well, where's SimplePractice's form template library? Where's your forms packet can be available? It's all going to be, the links are on that page.
Next question here. What are some of the biggest mistakes a clinician can make when juggling administrative and clinical tasks in the first session? From Maggie C.
Oh, this was an interesting question. Let's see the next slide here. So I had to sit back and think about that. And I put into two categories. I thought, in my mind, the biggest administrative mistakes that people make are not getting the paperwork done before the first session. A lot of times people are saying, don't have the paperwork done, and they're like, oh, can I just sign this after the first session, or can I just do this after the session? And a couple times this has really burned me in the butt when I went ahead and said, oh yeah, that's fine. You really need the paperwork filled out to bill for that session. You need to have, in case they walk out during the session, they walk out after, they don't give you the paperwork later. You really need certain things filled out before the session. So you try your best to get everything filled out. And sometimes I've had people back in the day when we were doing all in person, you know, if they hadn't filled it out, I would just have them sit in the waiting room and fill it out and finish it. Even though that's going to cut into our first session, it does two things. It kind of reminds them, hey, you know, there are some boundaries here, and you know, they need to get things done first before we can do this. And also, you make sure that you get all the things you need. One of the things I am insistent upon is that they definitely have to be informed of confidentiality, all these things before they come in and start talking in a session, right? So there's a lot of things on the treatment contract that I think they need to understand their rights. They need to understand confidentiality limits and all that. But don't overwhelm clients, as I said, by giving them too much paperwork. Although I tell clients when I email them, hey, there's going to be an avalanche of paperwork. I'm sorry about that, but I just acknowledge it. Not checking your insurance coverage before this session. This is a huge mistake that providers make. And especially if you're a network provider, you definitely want to be checking insurance coverage. Clients could have a $6,000 deductible before their insurance will pay. You need to often start collecting the entire amount. If it's a deductible period, they may not be covered. They may think they have Blue Shield and they actually have Blue Cross. There's all kinds of things that you're not a network provider for them. It could be so many issues. So you definitely, now what should you ask the insurance plan when you call? Again, I got that freebie, another freebie to hand out, which is checking coverage, 12 essential questions. I've given this out at some other SimplePractice webinars, but if you didn't get it, I've put it again here for at our little landing page there, theinsurancemaze.com/intakes, and you can download that and start using it right away. It is updated for telehealth, so it has questions for telehealth to be sure when you're checking telehealth benefits for your clients, which you really need to do regularly these days. You know, it's really a changing field out there. Now, some of the biggest clinical mistakes, and again, this is all, everybody might have a different answer to this, but I would say number one is focusing so much on the need to take a history that you're not fully present in the session with the client. And I'm going to talk more about this today. I really think that sometimes we feel so much pressure from insurance plans and from our own desire to do it right and to get all the questions answered that we kind of lose the connection with the clients. And it's a really big mistake, because our number one, I'll emphasize this 100 times today, our number one goal in that session has to be connection with the client and really making that client feel heard and understood. And that's hard. It's hard when you have a lot of other competing agendas. And along with that is starting to fix without fully getting to know the client. Sometimes we feel very pressured to give the client something and give them like a little sampling, a little like a pig spoon, to say, hey, this is going to be great. You're going to get a lot out of us. And we already are starting to jump in and try to give them techniques and tools. And, you know, they're in so much, maybe so much distress, we feel compelled to give them something to let them know that you can help them. But I think in general, this is a mistake. First of all, you don't have a lot of time in that first session. And second of all, you haven't really taken the time to get to know what they've tried before that's worked, what hasn't. You haven't really gotten to know the client enough to start really implementing a treatment plan. So I think hold off on that. Try to resist your urges to jump in and just be present.
What are the administrative and clinical tasks of the first session? I want to be sure I'm not missing any. From Steve J.
Okay. So these are the ones I come up with. administrative tasks are the first session, and there are a lot. You have to make sure all the paperwork has been completed and signed. You got to educate the client about your policies. You got to address any questions or concern they have about your policies and about insurance and fees and telehealth and confidentiality and all kinds of questions regarding the administrative, just how's it going to work? How often are we going to see you? All those things, right? If it's a family or couple session, you may need to review your secrets policies. Who's going to be the identified patient for insurance? What does that really mean? Whether are you going to see them alone? There's all kinds of separate things that for couples and families, you may need to review with them kind of administratively. And I do have a separate couples and family treatment agreement that I've written up in my practice forms packet. So if that's something that you are interested in purchasing, again, the link is going to be on that landing page. You're going to need to take a payment if necessary. If typically if you're off in the office, you're going to need to schedule the next session, which is a great time to review your cancellation policy verbally, even if they've signed something. So that's a lot, just the administrative side. That's as if you didn't have anything else to do. But of course, you've got all the clinical tasks. Now, I broke down the clinical tasks into two major parts. First, you have to get information from the client. And surprisingly, I know this is going to sound strange, but this may be the less important of the two parts that I'm going to talk about. You need to take a client history. It's super important, I know, but this is important. You need to begin to formulate your diagnosis and your treatment plan. I don't think I'm telling you guys anything new here. We're just kind of reviewing it. You need to screen, is this client appropriate for your practice? Sometimes we forget that part of what we're doing there is seeing whether or not this is a good fit. Everyone who walks in your office or is not going to be appropriate for your practice, and you have no obligation to continue to see somebody who isn't appropriate for your practice. And we'll talk more about that later, like what do you do how do you talk to the client about that? You should also be screening if you're doing telehealth, whether the client's appropriate for telehealth. There are some clients who are not appropriate for telehealth. Either they are needing in-person sessions because of their presentation, the complexity. Maybe I have one client, for example, who I had to switch from telehealth to in-person because he was really so isolated. He wasn't seeing anybody all week. His depression was deteriorating. He needed somebody, and he's a hoarder basically. So I needed to have eyes on him each week. He needed to get dressed and come out and come to interact with other people in human time. He was finding much better. He got much better when he came out to the session in person. Just being able to, again, get dressed, take a shower, drive across the city to come to me was in itself an intervention. And then for me to get an opportunity to really assess him better in person. And if client is using insurance, you're going to need to be evaluating him or her for a medical necessity, which we don't have a lot of time to talk about today, but medical necessity basically is insurance going to cover this? Do they think that there is a need for treatment because there is a diagnosis more than just a Z code? It's not personal growth work. So is this person just coming, everything's fine in their life, but they just want to talk about their self-esteem, or they just want to talk about better communication or better sex or career growth? That may be something that insurance will not cover if that's all that's going on. So you're constantly looking for depression, anxiety, insomnia. You're looking for some impairment, some actual symptoms. So that is definitely probably, I highlighted that in red because I think that's kind of really important to get done in the first session. But again, all of those things are probably less important than client engagement. That's my little term there. Most important is creating that safe space, allowing them to tell their story. I think we kind of forget how big this is for them to just come in and tell their story, and how difficult this may be. Tell it to a complete stranger. And you have to really work on that, probably, and push that part of you that really just has a million things you want to ask them, to really make sure that you are working on making them feel safe and coming across as warm and approachable and empathic, and also, though, professional and competent, right? We have to walk that line and kind of do both. You're going to want to invite questions. That's part of client engagement. You're going to give information about your therapy and your approach. And you're going to ask the client about their therapy goals. Now, you could put that under get information, but I think it is more about client engagement. I'm trying to engage them by helping them see where we're going to go together. What's the roadmap? And then, maybe more important than anything else on this page, is instilling hope that you and that therapy can help them. That client needs to walk out of that first session, if nothing else on this page happens, with some sense that you are on their team now. You weren't when they walked in, you were a complete stranger. You're on their team, and that maybe, even if it's a small hope, you're going to bring some help to them, or at least some companionship to them while they walk whatever road they're walking. So I just want you to step back, and I know this sounds funny from an insurance maven like myself, to say that actually the clinical side is way more important than the insurance stuff that you need to get done in the first session.
How can I cover all the bases with administrative tasks and still have time to collect a history and not have the patient feel rushed? From Enid G.
Enid, this is a great question. So here's my answer. You can't. Basically, you can't cover all the bases in the first session. And I think we just really need to let go of that. I'll help you kind of think about it, but we can't collect a thorough history. We can't do all the clinical things we need to do. There's going to be some things that are not going to get covered, and that's okay. That's really okay. We just need to let go of it. But I'm going to just tell you how I break it down for a 60-minute session. And this is very general. Obviously, it's going to depend on the client, but here's a sample timeline. So client comes in, the first 5 minutes, maybe you welcome them, you have a little small talk about the weather, or about did they have trouble parking or whatever. Then you start your history taking. And how do you start that? Could be something like, I'm just so glad you've come. So what made you reach out for support right now? So the first 30 minutes, I'm taking history. I'm asking lots of questions about the problem that's bringing them in, the history of how long that's been going on. Has it ever happened before? You know, all the questions. And we'll talk about a little bit more about that. But then I do something after the first 30 minutes of history taking, which I call informal structured functioning assessment, which basically finds out how have they been functioning. And it's just a quick, and I'm going to give you the outline of what that is included in that assessment. And then, okay, you're now what, 45 minutes into the webinar, into the meeting, and I say, okay, at this point you ask about their therapy goals, and I'll ask how you could do that. Talk about that later. Then I might invite questions, and then summarize what you heard and give hope. This may be, again, I highlighted it because this may be the most important thing of any other part of the session. Okay, I heard you guys talking about this and this and this. You know, what I see in this room, you know, you guys seem to have a lot of this, this, and this, if it's a couple. I hear there's this area that we need to work on, but you know, that's really doable. I think it's really doable. You have a lot of connection, blah, blah, blah. Whatever it is that their strengths, you bring that up, you really bring that out. and give hope. Like, I really feel like this is something that I work with all the time. I really feel like I can help you, and I'm looking forward to doing that, whatever. You schedule the next session and you review your cancellation policy. So what I wanted to do with this timeline is to highlight you really only have about 35 minutes to do history taking and assessment. So you can't possibly do a thorough assessment in 35 minutes. So let go of that. Just know that this is just chapter 1 of your assessment, and that's okay. But use reminders, I would say. At the end of my first session note, I will remind myself of things I need to come back to that I didn't have time for. You know, come back for depression assessment, or didn't get a chance to ask about substance abuse or substance use. You know, come back and ask that in the next session. So just kind of remind yourself that think of the assessment is not a one session thing, or the intake. It goes on for all throughout session therapy. Come on.
Cool. The next question. What should I be sure to ask in the intake sessions? What information is necessary to include in an intake note if insurance companies were to review a file? From Lauren S. and others.
Great question. So I've prepared a slide on this. Most insurance plans, I've done a survey of different insurance plans. I mean, not a survey, but looked at what documentation requirements are for first sessions. And I looked at 8 different insurance plans that were major insurance plans, and they pretty much agree. I was surprised on what should be in a first note. Now, when we look at this note, it'll tell you some of the questions you're going to need to be asking so that you can make sure you're covering these topics. So the common plan requirements for an intake note. And again, when we say intake note, you may not cover these all in the first session. So that's okay if you have it in the second session or whatever. But they definitely want to see the client's symptoms, presenting problem, and the problem history. How long has it been going on? What have they sought treatment before? You know, has it happened before? How severe is it? How bad is it? You know, anything around the symptoms. What's triggering it? Da, 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 da. Psychiatric history, including hospitalizations. Medications, include over-the-counter medications. Some of you have heard this story of one of my clients that I never used to ask about over-the-counter medications, but I did put this in my intake form, and he filled out that he was taking fuel. And I was like, what's that? And it turned out that it was a steroid that he got at like a health food market, like, or it had some steroid in it. And it was at one of these vitamin markets kind of places, healthy places. Anyway, the point is that it turned out that he was seeking anger management problems, and I asked him to stop taking that for a while and see if it made a difference, and it made a complete difference. So whatever was in there was having an effect on his mood. So checking over the counter, I've had one client who was taking NyQuil to get to sleep. Sometimes you have people who are, if you don't ask about over the counter, you don't realize that something could be interacting that's very important. So be sure to ask about that. Prescribing doc contact information. Psychosocial information, I think we all know to get this kind of thing. Again, that's something that could wait till a second session. Medical issues, relevant medical history, allergies, that could be on a form instead of in the session itself. Mental status exam, they definitely want this in the first session. After that, some plans really don't need it for every session note, but just to let you know, you definitely want a mental status exam for the first note, particularly. Risk factors and how you assess them. You know, client reports this, or I asked client that, and they said this. Particularly danger to themselves and others. Substance use assessment. You should for everybody be assessing their alcohol, drug, and even cigarette use. And I'm adding the word vaping here because that has become, you know, in some populations, way more popular than cigarette use. So this is something I think we should be asking about. And but that's more a Barbara thing than insurance plans probably aren't requiring that yet. Diagnosis and support for it, definitely. This is one that even if you haven't fully baked your diagnosis yet, if you're starting to hear support for a diagnosis, you want to be putting it down. What is the client support system? And definitely emergency contact information. Insurance plans want to have that probably in case there's a meltdown. And if you're doing telehealth, you should always have emergency contact information anyway. In case the client kind of melts down on the other end of the screen, you can have someone to call. Medical necessity, as I said, the need for treatment needs to always be documented and asked about. Basically, you're always kind of trying to figure out whether the client has some kind of a symptom and is impaired by it, which is the next one, I think. Yes, document any kind of impairment. So maybe client has symptoms, but they're not, we need to find out how impaired are they. So if they're anxious, is their anxiety impairing them? What does that mean? Are they having trouble going to work on time? Are they having trouble being as productive at work as they used to be? Is it impairing their relationships? Is it impairing them financially because they're making bad choices, or they're they have like a spending addiction, or what ways are the symptoms impairing them? So I have a whole article on this, how to document impairment. Again, I'm going to put the link at our landing page there at theinsurancemaze.com/intakes, and it'll talk to you about all the different areas of impairment and what are some examples to document to make your documentation stronger.
Do you have any tips about how to do it? Oh, what is that? Oh. I apologize. Looks like some kind of alert.
Yeah.
Do you have any tips about how to do a quick assessment of functioning in the first session? From Raina P.
Yes, I do. Yes, so I would encourage you to look up the DSM-5 criteria for a major depressive episode and memorize. Even if your client walks in and they don't have depression, I have found that this can be a great informal, structured questioning that I use for all my clients, frankly. And I've put it so you don't have to look it up. I put it on the next slide here. So this is kind of like an impairment assessment. And I say something like, wow, you've been dealing with so much. I'm kind of wondering how you've been coping. So you don't want to launch it by saying, well, I'm going to do an impairment assessment. Again, we try to come from your most casual self and talk to clients the way you would talk to somebody over the back fence, kind of. That's how I try to imagine it. So here are the DSM criteria, and I just have memorized these, and I just say to them, so have you been having trouble falling or staying asleep? You sleeping too much? How you doing with the sleeping? And if they say, oh yeah, I'm not sleeping very well, again, you want to quantify. So like, how many hours do you think you're averaging per night? So we want to get a baseline here. Or sleeping too much, again, what's too much? So are we talking 10 hours, 12 hours? What are you doing? Okay, how long does it take you to stay asleep? So try to quantify these. How is your eating, your appetite? Have you had weight loss, weight gain, lack of appetite? Are you binge eating? Any of these areas about eating. Have you had a loss of pleasure in things that used to be fun for you? If so, what? Tell me about that. And these are things you're documenting so that you can really measure progress in sessions. Loss of concentration, indecisiveness, loss of motivation, loss of sex drive or interest. Yeah, well, the same thing. Feeling tired, lack of energy. So I've just memorized these 10, and I just really casually in session look them in the eye and be talking to them, and hopefully it doesn't feel like they're being a third degree, yeah. How many degrees? Feeling bad about yourself, to low self-esteem, feeling guilty. feeling hopeless or helpless, okay? Thoughts of dying, not wanting to be alive, suicidal thoughts. So instead of saying, hey, have you been feeling suicidal? I soften that a lot and say, have you ever like just not wanted to be alive? Have you just like woken up and said, I just wish I weren't alive? That to me is a much more permissible, I want to say, question to ask clients. Sometimes people don't want or are afraid to tell you if they've had suicidal thoughts, but the not wanting to be alive, first of all, they kind of be like, oh, wow, you really kind of are going there and you're asking me in a soft way that I can maybe endorse. So there may be people who would endorse that, but not suicidal thoughts. So, or thoughts of dying. So you can kind of go from there depending on how they answer it. And then you want to do a little anxiety question that I throw in there, which is just, have you had any episodes where you just feel really anxious, you really feel nervous, keyed up? And then if so, you go down and ask more questions about that. So these are the 11 questions that I've memorized, and I think it's really helpful to ask in a first session. And then I normalize and educate. I say, wow, all this makes sense given what you're going through. And you might not realize it, but your answers tell me that you may be dealing with some, low-level depression. And that's understandable given, the stressors that are on you right now. So keep doing that in the session, just like normalize, of course, what you're reacting is exactly what's to be expected given your stressors. And that's the part that, like I said, is almost more important than all these answers to those questions. But you need to get the answers to all those questions at some point.
It's hard to interrupt clients at the end of the intake to wrap up. Any tips from Jeremy J?
Yeah, it can be. I have had some clients who walk in and they just talk uninterrupted for 35, 40 minutes, and it's hard for me to even interrupt them during it to ask questions. So you have those clients, and some of those people, you can really understand that they've really been sitting on a lot of emotions and have a lot going on, and it's hard. But sometimes you feel like you've unlocked a door and people are now giving this permission to talk to you, and it's hard to kind of put that back into the, some containment. So I guess one thing you can do is predict this at the start and say, now I am sure we will not have time in this short session for you to tell me all that you've been going through, but let's just see how far we can get. So that's reminding you and them that this is going to continue at a future session. We're not going to get it all done today, and that you're kind of allowing an interruption or permitting that there may be an interruption later. And then near the end, you could close the history taking when you need to by saying, I am sure you have only told me the tip of the iceberg, and there's so much more for you to tell me. But before we end, I really want to understand what you want to get out of our meetings. And then you switch to asking about therapy goals, which is a future oriented, right? So you've gone from taking history about the past and their to present to now we're going to start talking about the future. And that can help you switch out when you're of the history taking time.
What's a good way to ask about therapy goals in the first session from Zaya F?
I just say, I'd like you to imagine our last session together. And you say to me, I don't feel like I need to come anymore. I feel so much better. Barbara, you're an awesome therapist. I've gotten everything I wanted to get from these sessions. I kind of make it a joke. What will you have gotten? How will you be feeling and acting differently? And, sometimes they'll give me an answer that isn't one that I can use in a treatment plan. Like, I want my husband to start treating me nicer, or I want my kid to start stop acting like such a butthead or something. Sometimes you just have to help them. Yeah, okay, but how about you? How do you want to be feeling differently than we can't? Or I sometimes say, well, I'm sorry, I don't have the magic wand to control your son, or I can't control your husband. How can I help you? How do you want to be feeling differently? if I waved my magic wand, and I do have one of these little magic wands in my that I use, and I said that's another way I can approach it, to say, if I could wave my magic wand, how would you be feeling and acting differently? Or so it's a soft way, I think, to approach goals. And again, we want to be just as human as possible in that sessions. There's a very important part of this question, which is that you're helping them envision the two of you working together. You're helping them envision feeling better with you. And I think it's so important that they start to have a vision of feeling better, and that they did it by working with you. So this has a very important kind of subconscious message of having them visualize that.
Do insurance plans require that we do treatment plans after the first session? I don't always have enough information. From J to L.
Yeah, it's a great question. I always get this question in terms of like, when do we have to do the first treatment plans? Like, didn't get enough information. I would say most insurance plans that I've looked at don't say exactly when the treatment plan must be completed. I mean, I think if you call them up, they'd say, well, we'd like you to complete it after the first session. But as you know, as we've just said, it's sometimes hard to like see clearly what direction you're going with a client, or you may not really have a firm sense. But I would say most insurance plans expect that we do it after the first or at least the second session. So I'd say by the second session, at least you should have a pretty good sense. And your treatment plan doesn't have to be super, super specific. It could just be reduce anxiety is one of your goals, or reduce clients' depression symptoms of this, or client will be sleeping, more than 5 hours a night. So some of your goals, you probably are going to find out in the first session what the main issues that they're dealing with. I have a whole webinar about this called How to Write a 5-Minute Treatment Plan. So if you're not really feeling strong about your treatment plan writing, which most of us aren't, that's something most of us did not learn how to do. I do have the link to that webinar at theinsurancemaze.com/intakes. I also have a webinar about progress notes writing, which is related. If you've never learned to write good progress notes, or you're not really sure about how confident you would be if they were audited, again, I have at that same landing page, there's the link to that webinar and any other related webinars.
What if I determine at the end of the first session that an insurance client doesn't have a diagnosis and is just seeking personal growth work? From Maria G.
Yeah, and this does happen. Or it happens that sometimes you're seeing somebody who's has a diagnosis and then they get better, and there's a point where you feel uncomfortable putting down a diagnosis anymore. So it could be in the middle of therapy, or it could be right at the beginning. So you give what I call the medical necessity talk. You need to explain to them that you're happy to work with them on these issues. You love working on the topics of personal growth, with communication, with better sex, like we talked about, career growth. What is the meaning of life? What are they meant to do? Why are they on this planet? Those kind of questions. But that you're unable to bill insurance for this. That insurance only covers therapy that addresses a mental health diagnosis. So them just exploring these kind of personal growth issues are not going to be covered by their insurance. So again, it doesn't have to be oh, I can't see you. It just could be, hey, I'm happy to work with you, but I can't bill your insurance for that. So, here would be the price to continue to work with me.
What is the best way to send intake paperwork to telehealth clients? Should I worry about sending it via email? From David S.
Yeah, this is a great question, and I wish I knew more about this area. So, but I almost didn't want to take this question as one of them, but I thought, no, this is like a big question for people out there. So I'll just give you my very poor answer. Basically, yes, using client portals. If you use SimplePractice, they have a client portal you can send it that's confidential. and you know.
Jeez. Everything's bypassed.
Or if you use other practice management programs, have client portals, so that can be very helpful. You can use a secure email like Hushmail. Again, I'm not a specialist in that or secure emails. This is one that I've actually used. I have them mail it to me or drop it off at my office. So if they feel more comfortable, you can do that. Yes, you can even just send it to them via email, the blank form, because there's no private health information on there, and then they can mail it back or drop it off. So remember, it doesn't have to be both ways sent privately. The first way, it's a blank form, so there's really not too much. There's no private health information on there. But I did want to put a link here in case this is a concern for you. For more about HIPAA compliance, there's a lot of resources at Person-Centered Tech. If you're not familiar with Person-Centered Tech, I send a lot of people there. They are an organization that just focuses on therapists and technology and the intersection of the two. So on my landing page here, the insurancemaze.com/intakes, at the way bottom, I think, I put a whole bunch of different, I contacted Person-Centered Tech and I told them that I was doing this webinar, and they gave me a couple links that are particular to sending out intake paperwork and credit cards and things like that that have to do with, but talk to them, consult with them, check out their podcasts and articles. They got all kinds of good stuff about technology.
Next question here. Sometimes in the first session, a client asks to negotiate my fee. Can you talk about sliding fees? From Malika R.
Yeah, we could do a 6-hour webinar on sliding scale fees. This is something that a lot of people ask about, but I just kind of put the key points here. If you're out of network with a client's health plan or the client's not using insurance, you certainly can slide your fee. So, but you must have a full or a normal fee for a service. You can slide down. So let's say if somebody calls me up and says, what's your fee for me to see you for a 60-minute session? I need to have an answer for that. And if my answer is $150, that's fine. And then they say, oh, I can't afford that. Yes, I can slide down from that. The piece that I hesitate to mention is you can't say, oh, well, do you have insurance that you're going to be getting reimbursement from? And they say, yes. Oh, well, then I'm going to charge you more than my normal fee. Hopefully people don't do that. But you need to have basically a set fee for your service, but you can slide down. You can slide down all the way to 0 if you want, because the bottom line is if you're out of network with an insurance plan, the clients, you've made no promise to anybody about what you're going to charge for that service. Your policy can simply be that you slide your fee based on a client's stated ability to afford your fee. You don't need to verify income. You don't need to get their IRS tax statements. You don't need to make them, swear on a Bible about their ability to afford it. You can, as long as you have a sliding scale fee policy, this is my understanding, that you apply uniformly, you're good. And it can simply be, and most people, I would say, just ask the client, what do you think you could afford? If you can't afford my fee, what can you afford? And just remember that the sliding scale fee, not your full fee, should be reflected on any super bill you give them that they want to turn into their insurance. If they have out of network benefits, don't put your full fee. Your super bill should be like an invoice where you reflect only what the client paid, right? So it's not like if they go to the grocery store, and they pay for carrots and the carrots are 50 cents, you don't put the full fee, you pay what they pay for the carrots, all right? Same thing. Otherwise, it can be insurance fraud because you're sliding your fee up. I mean, you are putting a full fee that they did not pay, and that's going toward their deductible, or the insurance plan is seeing a fee that they did not pay. I have a whole webinar about that, billing for out-of-network providers, which talks in more depth about this and many other topics. And again, this is a SimplePractice one, the Ask a Biller series. I also have one on my website, which is much more thorough. It's a 2-hour webinar just for out-of-network providers, but we did one for SimplePractice, and it's there.
Sometimes clients don't come back after the first session. Any thoughts about what I could do differently to prevent this? From John R.
Yeah, John, this happens to a lot of us, and sometimes it's a good thing when people don't come back. Maybe it wasn't a good fit, but if this is happening, it's something that if somebody doesn't come back, I'm always looking at why, and sometimes I email them and ask for feedback. And it's interesting how often people will give you feedback. I think our world people are used to giving feedback. So I definitely would reach out to the client and say, hey, I haven't heard back from you. If there was anything that I said or did that made you decide not to come back, I would really welcome your feedback, even if, you decide not to come back. It really helps me grow as a professional and as a person. People are often interested to give you that feedback, but I would also say monitor your own anxiety. Sometimes we don't realize that it's kind of stressful for many of us to meet a new person and try to meet their high expectations of us. And sometimes we go into that first session with more anxiety than we really realize. It's a lot. It's a lot on us to be entertaining and to be professional and to be approachable and to all the things we think we need to do in that first session to get all the information and to not ask the wrong questions and to not push them too much, but at the same time push them enough to tell them that they're safe to ask those, that we want to hear the answers to questions. And it's tough to really go through all that. And sometimes, particularly for those of us who are introverted, it is something that we may not realize that our anxiety may be coming through. So I really encourage something like meditation or whatever you do to kind of just be present in that session. Do your mindfulness, do your just reminding yourself to lower your expectations in that sessions, and just all you need to get accomplished really is to connect and be present, and you can do that. Make sure that number one priority is really just listening. Work on that eye contact, work on communicating compassion. Maybe you need to up the number of times that you say something that's reflective and compassionate, and like, oh my God, that must have been so hard, or, oh, wow, I can't even imagine what that was like, or just anything you say or do that. And I sometimes have to work on this. I'm so in my clinician mode that sometimes I forget to just be personally warmth. Slow down. Again, I'm just saying this over and over, but put connecting before history taking. And comment more on their courage. Sometimes we see people come in and we have all these questions. We don't realize how hard it is for them to come in, how much courage it takes to go to a therapist and to talk to a complete stranger. And whenever you hear something that's even slightly about a strength, comment on it, on their coping. Sometimes I say things like, I'm surprised that you may feel like you're not coping that well, but I'm surprised you're still putting one foot in front of the other. Just really say, wow, given all that you're going through, I'm amazed you're doing as well as you are. And definitely just keep talking about courage, especially, and also with couples, like how courageous it is for them to bring their relationship to a therapist, when we all know that sometimes that can help really put more tension on a relationship and bring up issues that they've wanted to avoid. And so really commenting on the courage, and focus more maybe on giving them hope. Again, we need to keep in mind that this may be the most important part of that first session. And I'm really aware as I'm talking that this is all very clinical. A lot of what we've talked about today is clinical, and usually when I come in and do these, it's very billing oriented and very administrative oriented. And I hope nobody has been disappointed as we go through these, that there's a lot of clinical here, but hopefully this is also helpful.
Next question. What if someone comes to the first session and they aren't appropriate for my practice? From Marissa C.
Yeah, great question. So I'm just really honest with people and I refer them. I say, I would really love to work with you, but I'm sorry to say I really feel I'm not the right person to help you. The issues you're dealing with are really not ones I have the proper amount of training and experience to help you with. It would be like, I give something like, it would be like if you had a foot problem, it would be wrong if I didn't refer you to a foot doctor. I mean, you could keep coming to see me basically, but I don't want you to waste your time and money to see me when someone with more training could help you feel better and faster. I mean, that would be kind of against what got me here. I want people to come in here and come to the right professional and get as better as fast as they can. And it would feel so wrong to me for me to help be the one to help you when there's somebody out there who could do it better. When I've had to do this, which isn't that often, I feel like their clients really respond well. I mean, and I sometimes say, I wouldn't want to see me if I were you. Like this, I would want you to, if I were in your position, I would want the therapist to refer me to somebody who could help me, has more training, and let me see if I can help you find somebody.
How do you handle questions like, am I crazy? Or can you help me? Or how many marriages have you saved? From Beth L.
Yeah, so a lot of people ask those questions in the beginning to kind of feel you out, I think, and see, how are you going to handle my concerns? So I would say that your handling of the question may be way more important than the answer. They're probably seeing is, first of all, is it okay to ask questions? Is it okay to show that they feel crazy? Is it okay? What reassurances can you give me? So I would say I kind of wonder, and I would say something like, I promise I'll answer your question. It's a great question, but can you tell me what led you to ask it? So instead of just saying, what led you to ask that question, which I feel like might make them feel a little put off, I reassure at the beginning and just say, I promise I'll answer. It's a great question, but can you tell me what led you to ask? That way, whatever led them to ask might help me answer it. And then I normalize, I say things, something like, that's a great question. It's a question I get a lot, so they don't feel nuts. It makes sense you'd ask that, given your situation, whatever. Be sure that we reassure them. And acknowledge reality. We all feel crazy sometimes or wonder if we're beyond help, that it's just completely normal. And it can be scary sharing our most personal thoughts with a complete stranger. I mean, I am a complete stranger. And so what you're doing is very courageous. But then exude confidence. I would say therapy doesn't come with guarantees. I can tell you, though, that every day I successfully help people who are struggling with the same issues you are. So again, I'm telling them they're not crazy, they're not alone. Everyone's coming in and asking for these same things, and I have helped other people. Don't make guarantees. So here we're reviewing the freebies. We've got the checking coverage handout. We've got the article of the first contact. We've got the impairment article, we've got the slide handout, we've got links to all the resources and webinars we've mentioned. You can join my mailing list, all at theinsurancemaze.com/intakes. And there's my contact information if you want to follow up with me. And I'm really looking forward to talking to you and answering any questions you might have. Yeah, I hope you enjoyed today's webinar.
Yeah, let me just chime in and say, it doesn't look like we have time for the open Q&A just because we're in the last 30 seconds here. But I do want to reiterate that this recording is going to be up in a few days at this the website that was just up there a second ago.
Sorry.
No, that's cool. Yeah, so go there in a few days, check it out, rewatch it if you want to, go over it again, check out all of the other ones that we have there, and we hope that it helps with anything you've got going on. All right, everybody, take care, and we'll see you next time.